Hi everyone, this is the overview for adult vancomycin pharmacokinetic per pharmacy protocol. So this would be very commonly seen in every hospital that you might be going to. Literally, pharmacists are running the pharmacokinetics protocol just because we are expert in it and we are able to dose it very well in patients. So medical staff goes to us a lot whenever they have somebody on vancomycin, or another more rarer pharmacokinetics that we do is aminoglycoside. But again, it's very rare. You would rarely see it being used right now in clinical setting unless it's very severe where they need aminoglycoside. But you will definitely see vancomycin either in your hospital API or medicine API, and you'll have to know on how to dose the vancomycin and monitor and adjust it. So in terms of protocol initiation, a lot of times physicians will order like a placeholder, such as placeholder like adult vancomycin pharmacokinetics per pharmacy protocol, which means like they are ordering pharmacists to initiate vancomycin and also to monitor as long as the patient needs to be on the vancomycin. And depending on the hospital, they have their own system and protocols in terms of how they monitor it, because like they need to keep track in terms of patients who are on the vancomycin protocol. A lot of the institution will have different goals. A lot of the institutions are now using the AUC monitoring goal instead of trough-based monitoring process. So a lot of times, you just have to check with the hospital which one they are using in terms of their goal monitoring. The pharmacies, again, as always, before they make a recommendation, they'll always have to check on the patient's chart review, make sure like everything is okay for them to initiate the vancomycin before they dose it. And they do a lot of documentation for the vancomycin just because they're going to be the one who dose it, who write the orders, monitor anything that are happening with the vancomycin. They need to document it as a note, and so that the other medical provider can see what's been done for the vancomycin. They're being updated in terms of like, okay, they're still on vancomycin, it's just that the pharmacists are dosing it, right? In terms of the dosing wise, there are different patients that you might see it being dosed. So one is those patients who have normal renal function, or maybe those who might have like mild CKD, at baseline, but as long as they're stable, they don't have AKI, those patients we can dose very quickly. And a lot of times we, especially if you do AUC based monitoring, we can get to their goal pretty quickly instead of those who might be on renal replacement therapy like hemodialysis or continuous renal replacement therapy. So those are the first thing I will try to look at to see what's their renal function looks like. So let's kind of talk about those who are not on renal replacement therapy or not on hemodialysis or other continuous renal replacement therapy. First, you want to know what's their chronic clearance, right? Those are very important because vancomycin cleared renally. So if they have renal impairment, then we need to take consideration with the dosing. The current clearance, though, I think one thing that might vary is the weight that you use, right? The other one is going to be the same. The weight, you might use in ideal body weight, actual body weight, or adjusted body weight. And it depends on what your justification is, right? So for most patients who are not overweight, BMIs, normal between 18.5 to like 24.9, usually I use the actual body weight. I use ideal body weight if they are overweight, that's kind of like my cutoff. But sometimes, you know, hospitals or different pharmacists will say like, oh, if, you know, they are having, you know, they're having um, the ideal body weight is 20% lower than actual body weight, for example, you know, like you might use the ideal body weight instead. And then you use adjusted body weight when the actual body weight is 120% more than the IBW. So like 100% to like 120%, you use the IBW. So different pharmacists, different hospital, you know, will have different threshold in terms of like when they use different weight. Again, as long as you have the justification in terms of you know, the weight that you are using, it should be fine. And it's typically around the same, you know, they might go up to like 130 or like 140. But again, I usually do it by the BMI cutoff, you know, so if it's normal, then I use the actual body weight. If it's overweight between BMI 25 to like 30, I use the ideal body weight. And then if they're obese more than BMI of 30, then I use adjusted body weight. That's just my practice. A lot of times, again, different hospital, different providers will have different practice style. Some will give a loading dose, which is like a higher dose in the beginning. And then the maintenance dose will be like a lower weight-based dosing. And this is typically if they're more severe, complicated, infectious, you know, and if, you know, you anticipate them to get to the steady state later, you know, if they're obese, for example, you know, you might want higher dose in the beginning so that we can load them and get them to the steady state as soon as possible. And then all doses should be rounded to the nearest 250 increments. You don't do 1200 milligrams. So very, very important to take note of. And this happens in every single hospital, single practice that I've been on. So vancomycin is always rounded to the nearest 250 milligrams increments. And the way in this protocols, for those who have non-renal replacement therapy patients, you will do AUC monitoring. And the way you do that, let me show you the calculator that you'll be using. And this is just a one specific calculator. Different hospital will have different calculator as well. Again, so double check with your institution. So this is the calculator that you have. Basically, the yellow highlighted one, you'll have to calculate you have to input some data. So for example, the age, right? In this case, I have 70 years old patients. And then let's say they're 5'4", you know, like so 64 inches, 5 feet, 4 inches. And then let's say their actual weight is 70 kilograms. And then based on the 5'4", you calculate the IBW being 54.7. And let's say they're female gender. And their serum creatinine is 2.2, you know, and maybe they have CKD stage 4, for example, you know, so they're at baseline serum creatinine. So we can do that with AUC monitoring. If they have AKI, that means that, you know, they're gonna have fluctuating renal function in the next few days, right? So a lot of times you might want to dose it, you know, not with AUC monitoring, you might want to dose it trough monitoring, or if you want to dose it with AUC monitoring, you can, but maybe like you might have to monitor that level more frequently than, you know, what's recommended. And then this is just the serum creatinine that you use for the calculation in the bottom. And okay, now we're just doing the initial dosing, all right? Why we have two different columns for the serum creatinine, because sometimes when somebody have normal renal function, you know, but they're elderly, a lot of times, you know, like we threshold them to like 1 essentially. So for those who are 65 and above, usually I will just use serum creatinine of 1 because their renal function will automatically declined. So we don't want to overdose them and cause adverse events, so that's why we are being more conservative in elderly patients, having it as one. If it's more than one, if they have CKD or AKI, then definitely use the actual serum creatinine. And then this will automatically calculate your creatinine clearance. Again, you should calculate your own creatinine clearance on your own, because this creatinine clearance is on default of using the IBW. So for example, if they're normal weight, then you should use the weight, right? The actual weight instead of the IBW. So you should still calculate your own creatinine clearance. If they're overweight, BMI is more than 30, then I would want to use the adjusted body weight, right, instead of the ideal body weight. And so this calculator would not calculate the weight based on the adjusted body weight. So you have to calculate on your own, and then if you calculate differently, your creatinine clearance that you use are different than what they're automatically calculating here, then you just input it in here. Like you can just type in on here. Once you have everything in there, then they already automatically calculate, every single pharmacokinetics that you are taught to calculate on your own, right? But they're calculating it automatically already. I would recommend going back to, how you would calculate pharmacokinetics. Just again, different institution might have different way of monitoring the vancomycin. If you do the trough monitoring, sometimes you might have to calculate the volume distributions, the vancomycin clearance specifically, and the KE and half-life as well. So knowing how to do that will be very beneficial in that scenarios. But in this case, they already automatically calculated based on your parameters that you put in here. And then you just have to figure out which dosing that might, patients might need to, might fit with to get the goal of 400 to 600. A lot of times, rather than kind of like just jotting, putting in like a bunch of different numbers to get the goal, I would calculate the weight-based dosing first, because in general, typically for average patients, the dosing is typically 15 to 20 milligrams per kilogram. And then based on your creatinine clearance, you can determine the interval. So in this case, let's say we'll take 15 milligrams per kilogram for this patient, right? And you just times 70. So 15 times 70 is about, let's see, 1,050. So again, like I mentioned, right, you don't dose it, you dose vancomycin increments as 250 milligrams increments. So either you do 1,000 or 1,250 for this patient. Let's say 1,050 is closer to 1,000, so I'll just put the dose of 1,000 in there. In terms of interval, creatinine clearance is very low, CKD stage 4, right? So probably not gonna schedule it too frequently, right? Because they're gonna get overdose. So a lot of times, if they're lower at this, I'll probably do the lowest frequency in general. It's gonna be Q24. So let's say it's 24 hours. Infusion time, depending on your dose. In general, you should not go over 1,000 milligrams each hour. So in this case, it's 1,000 milligrams, right? So at least you have to infuse it over 1 hour. If it's 2,000, you should infuse it over about at least 2 hours. So we put it one in there. Now they give you the, calculate automatically in terms of, your AUC, what anticipated AUC you're gonna get with this dose. Well, it's so much over than the goal, right? So you have to keep playing with the dosing or the interval, right? So let's say we'll do 750. A little bit closer, let's say 500. Still a little bit supratherapeutic, okay? So we need to decrease the dose a little bit longer. So 450, now it's perfect, right? Another thing you can do, instead of decreasing the dose, you might be able to get out with decreasing, lengthening the interval, right? So maybe instead of giving them once daily, maybe once every other day, let's see, 48 hours, right? So let's see. So again, All right, so it gets to the AUC of what we want it to be. So that's how you kind of like explore around with the initial dosing and how to get to the initial dosing with anticipated AUC at goal. For the bottom part is level analysis. This is when you are getting your levels already. And you get typically once, if you're going to monitor AUC, you're going to get peak and trough. So a lot of times, for example, your peak is 50 and then your trough is, let's say, 14. And you have to put in, again, like all the yellow highlighted needs to be filled with some data, right? So the time between dose started and peak, and this is typically, like from the dose to the peak, the end of the infusion to the peak. Usually we want to wait for about 2 hours until the vancomycin gets distributed, right, throughout the body. For example, if you infuse the vancomycin on your left arm, and then a minute later you get vancomycin lap on your right arm, it's not going to get there, right, in a minute. So that's why we need to have time until, after the end of the infusion of the vancomycin, to let the vancomycin distribute to the whole body first, right? So that when we get the levels, it's not going to be zero or like overdosing, right? If you get the levels on your right arm, if you infuse it there. So that's the idea behind it. And then this is asking your time between the dose started and the peak level. So typically, I mentioned, right, usually you wait 2 hours after the end of the infusion before you get the levels, plus the infusion time. So for example, we did the, let's say 500, right? Let's make it simple. 500 and then 24. So at least you have to infuse it 30 minutes for this time. But a lot of times hospital will just infuse it at least 1 hour for anything below 1 gram or 1000 milligram. So let's say they infuse it 1 hour plus 2 hours, for at the end of the infusion until when the levels are taken. So it's about 3 hours, right? And the real time is going to depend on when you look at the medication summary, right? It's gonna give you the information in the EHR setting in terms of what time is the vancomycin start being infused, and then how long it get infused, and then how long, like what time specifically the levels are taken, right? Because it's not going to be perfect 3 hours. It's going to be maybe like 3.2 hours, or 3.5 hours. Maybe they delay the peak level by like a half hour, so it's going to be 3.5. So again, like you have to look at your EHR to make sure that you're giving the right hours, or like the time between the dose start and the peak levels. And then the time between trough level and next dose, typically it's about between like 30 to like 60 minutes before, we obtained, we administer another dose, right? So again, it will depend on your EHR data. So again, it's not going to be like perfect 30 minutes, 0.5 or like 1 hour. It might be like 0.75, if it's like 45 minutes or something like that. So let's say it's 0.5, right? They obtain the trough 30 minutes before the next dose. Then we put it there. And then I give you another levels in terms of like, okay, based on this, the dose that you gave before, 1,000 or 500 Q24, you get the levels after that. And this is kind of like the peak and trough you get, and this is kind of like the pharmacokinetic parameters that they're getting, right? And kind of like the KE, the half-life based on the data. So this is real data versus this is more anticipated, right? Based on the calculation, we predict it's going to be 450. But then you're going to get a real levels, and then based on this number, you can get a new dosing in terms of, what would give them the perfect dosing. So this one is real clearance value. So let's say if we put in the same dose, right? 524 Q24, and the new systemic is going to be 1 hour again. Let's say, okay, so so actually this dose, based on the real actual levels that they were being obtained from the patients, this dose actually give you supra-therapeutic levels, right? You see like the AUC being monitored, being calculated is more than 600, more than the goal. So we need to decrease it further. Maybe we go 250, see how it looks like. Now it's kind of like subtherapeutic, so we can't do the dose decrease, but what about frequency, right? Maybe do 48 hours. Still subtherapeutic. So let's say we can do, every 12 hours increment, for example. So let's say 36 hours. It's not ideal, but if you really, really need to, then we'll have to do that, right? Because we don't want the patient to be subtherapeutic and also supra-therapeutic. Let's say. Okay, so it's better. Another thing you can do, you can probably increase the dose. So it was 500 Q24 before, right? What about we increase the dose, but lengthen the interval too, right? So if we do 750, let's say lengthening it to like 48, right? Because when we do 500 and then it's Q48, it's subtherapeutic. But what if we increase the dose a little bit and do 48 hours? So now it's becoming therapeutic, right? Between 400 to 600. So that's, you kind of like can play around with the dosing intervals, see like what is the best situations, like again, 36 hours is kind of a weird schedule, right? Like you don't dose it at the same time every other day or like every day. You're going to be dosing it like once in the morning today and then 2 days later at night. So it's kind of like a little bit complicated. So I would rather do like 24 hours increment instead of 12 hours increment in that sense. All right. So that's kind of like how you do the vancomycin AUC monitoring. Let's kind of go back to the vancomycin protocol. So once you obtain, you provide the patient their initial dose, then again, like I mentioned, right, you're gonna get their levels, like the peak and the trough, and you will have to repeat measuring them until they become therapeutic, right? Otherwise, we're not going to be sure if they're going to be therapeutic or not. We can predict like if they're going to be therapeutic or not, but we still need to make sure with checking the levels. And once they're stable and if they're going to be on vancomycin for a long time, then you'll just monitor their levels 5 to 7 days once they're therapeutic. And if they sometimes they might have normal renal function and then the next day they get AKI in the hospital, that's even though if they're going to be stable, or something like that, or their renal function changes at one point after being therapeutic, then you might want to get the levels again, because again, right, the vancomycin clearance might be different. So if they have AKI after being stable on vancomycin dose, your level might be supratherapeutic, right? Because their clearance is decreased. And then if their AKI resolves again, right? Then their clearance is gonna be faster, and you might want to increase the dose for vancomycin. So that's kind of like the idea behind when you're gonna repeat the dosing levels. So just make sure as well. One caveat, the AUC, you can get the levels right after the first dose. But for trough monitoring, you have to wait until steady state first. So just make sure, you get those. And sometimes like different on the hospital as well, like the AUC monitoring, they might want you to monitor the levels at steady state as well instead of after the first dose. Again, depending on the hospital protocol. So just kind of have justifications why you might want to get initial dose and why you might want to get the steady state. For example, if they're normal, you anticipate that they're going to get to goal pretty fast, no other comorbidities, you probably can wait until third to fourth dose, right? But if they're having AKI, renal function frail, you're worried that they might be overdosing or underdosing, then you might want to get it faster than waiting until steady state in that sense. Now we kind of go to those patients who might be on renal replacement therapy if they're on hemodialysis. You're not going to be able to do AUC monitoring because they're not clearing the vancomycin, if that makes sense, right? Vancomycin is cleared majority from the kidney. So if you have ESRD, which means that you might be on hemodialysis, right? You might not clear the vancomycin until you get hemodialysis, which is typically they're being scheduled every other day, 3 times a week sort of thing. So you just can't do AUC monitoring in that sense because the level is going to be your level is going to be pretty much similar, steady, stable, because I'm not clearing the vancomycin. So for hemolysis, basically what you would do is you dose based on the weight base again, initial dose. Typically, like I mentioned, right, it's always 15 milligrams per kilogram. For hemolysis, you don't exceed 1250. And then you will get the next levels around the next dialysis. So for example, you are giving the dose today, and then they're due for dialysis tomorrow. And so what you would do, you give the dose today, and then tomorrow, before the dialysis, you'll get the levels to see what the levels are. Or another way you can do, you get the dialysis, you get the levels after the dialysis. This level's going to be random levels, right? It's not going to be a trough because, again, your vancomycin is not going to be cleared. It's not going to, it might be a peak, but again, your level is going to stay the same until your dialysis. So it's going to be a random levels. It's going to be a peak, essentially. Again, you can either do pre-hemolysis level or post-dialysis level. A lot of times, hospital will do pre-hemolysis, so you can start making plans on what dose you're gonna give after the dialysis. And if you get pre-dialysis, like I mentioned, right, your vancomycin level gonna be at their peak level, basically. And so, how would you get the trough level, right? Because a lot of times we dose it based on trough. Like our goal is the trough level, right? 15 to 20 or like 10 to 20 based on your indication. So how do we make sure that we get how do we know like what's the level gonna be after the hemodialysis, right? So if for general hemodialysis, high flux, with the general setting, typically your vancomycin will be filtered about 40 to 50% of it. So for example, if you have pre-dialysis level of 30, then after dialysis, your post-dialysis level is going to be about 15 to 18, essentially. So that's kind of like extrapolation, right? It's not going to be your exact level unless you do the post-HC level, but you can extrapolate it based on that fact of the vancomycin being cleared 40 to 50% of the dose. So a lot of times different hospitals will have different protocols in terms of like how would you dose it afterwards, after the dialysis. In this protocol, you want to do supplemental dose, so basically giving another dose after the hemodialysis if the pH level is below 24 or if the post-HG level is below 20, like I mentioned, right? Like your goal is typically about 10 to 20 based on your indication. So we want to keep the levels around that levels. So if you're lower than 20, then we want to add another dose. And if you're below 24, that means like after dialysis, if you take like 24, right? It's going to be 12 to like about 15. So you're going to be a little bit subtherapeutic. So that's why you're going to do another supplemental dose. And supplemental dose in this protocol can range around 10 to 20 mg per kg. And, to reach specific goals depending on the indications. And the 10 to 20 is a guide, it's an average weight-based dosing after the hemolysis. Some patients might need lower or like higher dose depending on your levels, right? So for example, you give a vancomycin and then you, for example, 1,000 milligrams of vancomycin, right? And then you get the post HD levels then after the next dialysis being 22. So after the first hemodialysis, then you're not going to be giving another supplemental dose, right? Because it's above 20. And then you do another dialysis, the second one, then it goes below 20, right? So after that, you might want to give supplemental dose, but you have to see first, like what's their 10 to 12 milligrams per kilogram, right? You probably don't want to give another like 1,000 milligrams just because it lasted 2 dialysis for the patients to clear out the vancomycin. Typically, we want to give the dose so that you can dose it after every hemodialysis. So essentially, maybe you have to decrease the dose by 50%, it's like 500, so that the next dialysis, it will clear out the dose, not too low, but still at a good level, and then you can just schedule like 500 every other, after every dialysis, essentially, because we don't want them to get exposed to like very, very high level of vancomycin for a long period of time because of the adverse events that they carry, right? So again, not everybody will get supplemental dose of 10 to 12 milligrams per kilogram. You have to base it on their previous dose and what the levels are after that dose and so on, sort of thing. So once you get levels, adjust the dose, you get another levels with each hemodialysis sessions, and then basically you continue to do that until 2 therapeutic levels, and then you can continue do it every third hemodialysis sessions or weekly, essentially. That's for hemodialysis when they're getting intermittent clearance, right? But there's another dialysis called continuous renal replacement therapy, which is they're getting hooked up into a dialysis machine, basically 24/7. It's continuously getting filtered, so basically getting a kidney device. In this case, depending on your type of the renal replacement therapy, you might have different dosing, different frequency. The difference between these are going to be the rate of the filtration and clearance. So the higher the clearance, like for example, the CVB HD, usually it's faster, right? So you might have like the same dose as CVVH, but like maybe higher dose than the CVV-HDF, but more frequent, right? Like Q24 versus like Q24 to like 48 hours, and kind of like going from there. So a lot of times we do the renal replacement therapy like as if we are dosing it when somebody still have some renal function left, like either CKD or like normal renal function, because they're basically the CRRT are acting, functioning as a kidney for the patient, an external kidney, essentially. So those are how you follow Vancomycin protocol and use the Vancomycin AUC calculator that is attached to the protocol.